Yeah, we did.
May I borrow it, please?
Sure.
Okay, I'll run and get it.
All right, thanks.
Thank you.
Hey, y'all.
I guess I didn't bring it back.
We will give everybody a couple more minutes and then we'll get started. Can y'all hear me okay? Okay, good. Kendall, that doesn't look like the P9 workroom.
It's a little different.
Kendall, let's see the view.
Can you see it at all?
We'll start at 12:05. Can somebody say something? I think y'all can hear me, but I'm not sure if I can hear any of y'all.
I can hear you.
Can you hear us, Tim?
Philip, are you talking? I saw your
Yeah.
your box light up, but I'm not hearing anybody.
Okay. Well, I'm talking.
There we go. Okay. So Courtney said that she can see. Can you hear me, Courtney? All right. Okay. So it looks like this is going to be a one-way street here in terms of audio, which is okay. If you guys have any questions, you can just type them in the chat box, and we'll make it work. And if I miss a question, somebody who's got their video on, just give me a wave. Okay, so let's go ahead and get started. Okay, so today we are going to talk about acid-base disturbances. So I have no financial disclosures, or at least since I stopped selling acid, I no longer have any financial disclosures. In terms of our objectives, here's what we're going to do today. So I want to make sure you guys understand the pathophysiology of the 4 primary acid-base disturbances. Make sure we understand the appropriate compensatory mechanisms. Be able to identify when there are double and triple disorders, and then kind of develop an approach to diagnosing and treating acid-base disturbances. We're going to focus on all 4 of these during this session, but then in the acid-base workshop session at 2 o'clock, we're really just going to focus on the 4th one. I think you'll get the most out of this if you can attend both sessions. Okay. All right, so let's get started. There are some beautiful nomograms out there that can help guide you in, diagnosing some type of acid-base disturbance. Frankly, to me, these kind of confuse me, but if they don't, and you're somebody that likes these, let's at least forget that they exist, at least for today. Okay, I want you to understand what's actually going on and not just rely on the nomograms or the medical calculators or whatnot. So let's forget about these for today and try to really understand the issues at hand. All right, so let's start with a few basic principles here. We're going to start really basic with pH. Now, pH is equal to the inverse log of the amount of hydrogen ions. Okay, so this means as the amount of your hydrogen ions go up, it's inversely related to your pH, which will go down. Okay. So what that means is sometimes log scales can be a little confusing. A pH of 7 means that your total amount of hydrogen ions equal 10 to the -7th moles of hydrogen. A pH of 8 is 10 to the -8. So if there is and a pH of 6 is equal 10 to the -6. So a pH of 6 has 10 times as many hydrogen ions as a solution that has a pH of 7. A pH of 5 has 100 times as many hydrogen ions as a pH of 7. And in simplest terms, an acid is a chemical species that can donate a proton, and a base is a chemical species that can accept a proton. And when you're in a solution, like all things within our body essentially is a solution, there's constant transitioning back and forth between this acid and the hydrogen ion and its conjugate base. There's a lot of different things that can affect these transitions and how often they occur and how much they occur. But just know that a solution is kind of made up of all three components. So the acid, the hydrogen ion, and the conjugate base. Using a simple example, such as hydrochloric acid, it exists in this acid form, as well as your hydrogen ion, or an anion, cation, and a chloride anion, which is negatively charged. But it's not just simple molecules like this. Anything that can cause or create an acid physiologically will exist in multiple states. So we'll keep coming back to lactic acid, which is the term that we use a lot, but lactic acid will transition back and forth from its acid form to a hydrogen ion and the lactate base. Okay, we'll see why this is important a little bit later. For all you chemistry nerds or anybody that took chemistry in undergrad, you guys may remember your Henderson-Hasselbach equation, which is this here. So what this equation does is allows you to estimate the pH of a solution that contains both acids and bases. Okay, so you know, unless you're in some type of chemical vacuum, you're not going to have just acid or just base. You're going to have multiple components of both, and this equation can be used to determine what the pH of the entire solution is. Now, when it comes to humans, principally your base is represented by bicarb and your acid is represented by CO2. And as you can see, a disturbance in either one will alter the pH. So in a healthy person, your CO2 and your bicarb are in constant flux to try to maintain this normal pH. But you can see based off of the scale, which is kind of a visual representation of your Henderson-Hasselbach equation, if you have a tip of the scale of one side or the other, it's going to alter your pH. So if there's too much bicarb, or if there's an increase in bicarb, your pH will go up, creating an alkaline solution, and vice versa in the other way and on the other side of the scale. So let's talk about our 4 primary acid-base disorders. Okay, so we have a metabolic acidosis, which in simplest terms is where there's too much bicarb. You have a metabolic alkalosis, too little bicarb. In a metabolic alkalosis, there's too much bicarb. For a respiratory acidosis, you have too much carbon dioxide. And for your respiratory alkalosis, there's too little carbon dioxide. So if we go back to our equation, this should make sense. If our bicarb drops, you have a decrease in your numerator, which will drop your pH. So if dropping bicarb is equal to forming a more acidic pH. Same thing for your metabolic alkalosis. If your numerator goes up, your pH goes up. And then this is all true for your respiratory issues as well. But here your CO2 is in the denominator. So as the CO2 goes up, pH will go down. In a respiratory alkalosis, if CO2 goes down, if your numerator goes down, your pH will react in the opposite direction. Okay, so some basic relationships that I wanted to cover before we get a little deeper. The other principle I want to talk about is whenever a primary acid-base disorder exists, the body is going to attempt to return the pH to a normal value. And it'll do that by the other half of the acid-base metabolism. So what I mean is, if there is a primary metabolic disorder, our body will compensate using respiratory mechanisms. And if there's a primary respiratory disorder, we'll compensate through metabolic mechanisms. So you guys know all this, but we'll kind of just run through it quickly. Again, if you've got a metabolic acidosis, the compensatory mechanism is to increase ventilation. So if there's too little bicarb and your pH is too low, you can affect that by tipping the scale in the other direction and blowing off more CO2. Makes sense for a metabolic alkalosis. You're going to decrease ventilation to try to make the blood more acidic to neutralize the base from having too much bicarb. When it comes to renal compensation, when there is a respiratory disorder, your kidneys not only hold on to more bicarb in the setting of an acidosis, It also excretes more hydrogen, okay, which, like we said, that hydrogen you can kind of think of as being equal to acid. And then the opposite is true for your respiratory alkalosis. Your kidneys are going to excrete more bicarb, hold on to more hydrogen, okay? All right, so when it comes to these 4 disorders, there are questions that you've got to consider for each one. For your metabolic acidosis, the first thing you got to figure out, is it GAP or non-GAP? You got to know, is there another metabolic disorder at the same time, specifically a non-GAP acidosis? And do you have an accompanying respiratory disorder? Okay. For metabolic alkalosis, the big question you need to ask, is it chloride responsive or chloride resistant? And then for your respiratory disorders, you're asking the same questions. Is it an acute issue or chronic issue? And then is there an accompanying metabolic disorder? Okay, so these are really the, was it 4 or 5, 8 questions you've got to ask for each, or not for each, for any acid-base disturbance. Let's dive a little deeper into our metabolic acidosis. So again, your 3 questions: is it GAP or non-GAP? Is there another metabolic disorder? And is there a respiratory disorder? Okay, so this is the calculation we use to see if there's a gap. Okay, so your anion gap calculation, which we've all seen, sodium minus chloride minus bicarb. Okay, now this is what we use clinically, but it's really an artificial construct. This is not true in vivo. Okay, so in vivo it looks a little bit more like this. So imagine this as a cross section of our serum that contains all the positively or negatively charged ions. In vivo, you've got to have net neutrality electrically. So what I mean is, within the body, all positives have to equal all negatives. All right, so everything that's pink here is positively charged, everything that's green is negatively charged, and there may be different concentrations of each individual molecule, but overall your net charge is actually 0. But we all know that when we think about a normal anion gap, it's 12, which is not 0. And the reason for that is, if we were really being pedantic, this calculation wouldn't look like this. It would actually be, sodium plus calcium plus hydrogen plus magnesium, minus bicarb minus albumin minus lactate minus chloride, yada yada. That's what it should look like if we're being really pedantic. But luckily, sodium, chloride, and bicarb by far make up the heaviest concentrations of these ions. So we can infer if there is an unmeasured anion, which is usually pathologic, by using this equation. Okay. So sodium is your positively charged molecule, and then your 2 negatively charged molecules, which you'll be subtracting, is chloride and bicarb. Like I said, normal is 12, and that's the number we'll use today. Impact does give you a range of 4 to 16, but just for simple sake, let's use 12 today. And again, this 12 is an artificial construct. There's not really a gap of 12. Okay, in real life, your gap is always 0. All right, so let's say that we've added a bunch of hydrogen to the system, and like I said, hydrogen is that your pH is equal to the inverse log of the amount of hydrogen. So if hydrogen is added, it should drop your pH. So let's just, for example, say we added 10 hydrogen ions. So here's our sodium, 140. We've got 10 hydrogen, a normal chloride value of 104, and normal bicarb of 24. Now the body doesn't like it when we add all of this extra acid. So it's going to try to buffer the hydrogen by buffering it to bicarb. And so as the hydrogen gets buffered away, we're going to see our bicarb drop. And so now our anion gap equation becomes 140, a normal sodium, minus 104, a normal chloride, minus 14. Because again, we started with 24, but 10 of those molecules of bicarb had to be used to buffer that excess hydrogen. So in essence, what that does is it changes our equation and gives us this value of 22. And so you can see by the addition of an abnormal acid that shouldn't be there, your bicarb will drop, giving you this positive gap acidosis. Okay. Just as a quick aside, you can, this chemical reaction shows what's going on with the buffering. So if your bicarb is being used to buffer your hydrogen, you get this molecule here, which is electrically neutral, but unstable. So it quickly breaks down into water and CO2. And so this is what you breathe out. If you were to breathe onto a window, you're going to have moisture on there. That's your water, and the gas is carbon dioxide. So you can see by looking at this buffering equation how an excess acid can lead to appropriate respiratory compensation. Okay, so these are the main causes of our anion gap acidosis. I like the mnemonic KILL-U, which is ketones, ingestions, lactate, and uremia. So there's several different things that can produce ketones. Most commonly, we see diabetic ketoacidosis, alcoholic ketoacidosis, and starvation ketosis. But as I mentioned earlier, these things aren't happening in a chemical vacuum. All of these acids can donate a hydrogen. And again, it's important that they do that because it drops the bicarb as the bicarb buffers it. So again, take sepsis, for example. You have this production of lactic acid. It's going to exist in solution as lactate and hydrogen. Okay. All of these acids do that. For example, ethylene glycol is going to break down into oxalate and hydrogen. And what's going on is, for example, using our lactate, our hydrogen is going to be buffered by the bicarb, which leaves us with this lactate that we can actually measure in a lab. So let's look at an example using lactate. So again, we take our normal anion gap equation here, and we've added our lactic acid, which is again broken down into hydrogen and lactate. The bicarb is going to go down again because the hydrogen is going to be buffered, and it leaves this negatively charged lactate molecule. And so since we don't put this in our anion gap equation, but we're dropping our bicarb, which is a negatively charged molecule, you're actually adding to it, which gives you a positive anion gap acidosis. Does that make sense? So you're adding this whenever there's a pathophysiological acid. We're not measuring this directly in our anion gap. The hydrogen is going to be buffered by a bicarb. If your bicarb goes down, your anion gap goes up, leaving you with a positive anion gap acidosis. And that's true for all of these things. All these things will form a hydrogen plus some other base. Okay. All right, so that kind of begs the question is, what about a non-gap acidosis? Now, these are the most common causes of non-gap acidosis, and we're gonna dive into the anion gap equation in a second. But these are a little bit different than our anion gap acidosis chemically. Okay, what's going on here is that just like with our gap acidosis, your bicarb will drop because it's going to buffer that excess hydrogen. But you're also losing bicarb, whether it's in the stool or the urine. And unique to this group of conditions, hydrochloric acid will also be formed. Okay, so we'll talk about this. But again, these are the most common etiologies of non-gap acidoses. These are the three that result in loss of bicarb in the stool. These other two result in loss of bicarb in the urine. And the end result is that you're going to be left with hydrogen and chloride. Okay. So the reason for, this is why the other name for a non-gap acidosis is also called hyperchloremic acidosis, because as you pee or poop out that excess bicarb, you're left with these hydrogens that end up attaching to your chloride. So you get the formation of hydrochloric acid, which gives you your hyperchloremic acidosis. Okay, we'll look at why that doesn't give us the gap in a second, but just a quick reminder, again, if it's a non-gap acidosis, it's going to be hydrogen plus a chloride base. If it's a gap acidosis, it's going to be a hydrogen plus some other non-chloride base. And the reason the addition of hypochloric acid doesn't give us a gap is basic math. Okay, so again, here's our main equation. We're adding a hydrogen and a chloride. The hydrogen gets buffered, bicarb will drop, but our chloride nothing necessarily happens to this excess chloride, but you're subtracting a negatively charged molecule. So your total chloride is going up. So it's just arithmetic. If your bicarb is going down because there's a buffer, but you've got more chloride than you started with, the final answer, your gap value stays the same. So there has been addition of an acid, but since you're also adding chloride, your gap math gives you the same result. All right, so that's what we call a anion gap, a non-anion gap metabolic acidosis, or hyperchloremic metabolic acidosis. Okay, so let's look at it a different way, because sometimes that can be a little bit confusing when you're doing equations. This, like I said, your anion gap is comparing your positively charged molecules to your negatively charged molecules. So this is normal, so this is all your sodium. Over here are the two negatively charged molecules that we measure, chloride and bicarb. And then your anion gap really is just all of these unmeasured anions, which usually equal about 12 in mathematical terms. So in the setting of hyperchloremic or non-gap acidosis, you can see your gap stays the same. There's no difference in this gap and this gap, but as your bicarb goes down, your chloride goes up. So again, hyperchloremic, non-gap. Alternatively, if you're looking at a high anion gap, there's no excess chloride. This chloride is equal to this chloride. Your bicarb drops, which means to maintain electrical neutrality, there has to be some unmeasured anion, which is often something like lactate. Okay, does that make sense? Does anybody have any questions about that before I go on to the next question? Okay, I'm not hearing anything, so I'm guessing that's good news, but I don't see any questions in the chat section either. All right, so like I said, you got 3 questions to ask for your metabolic acidosis. We've talked about, is it gap or non-gap? Next question you got to ask is there another metabolic disorder? Okay, so this is where I would usually ask, does anybody know how you determine a metabolic, if there's an addition of a metabolic disorder in the setting of a gap acidosis? But since nobody can talk or I can't hear you, I'll give you the answer. So you determine that by your delta gap, or what we call the delta delta. So delta delta is using a correct, or determining what your corrected bicarb should be in order to see if there's another metabolic disturbance in the presence of a metabolic gap acidosis. Okay, so this is what it looks like mathematically. You have a corrected bicarb, which is equal to your measured bicarb plus the actual anion gap minus a normal anion gap. Now, what you can plug in all your labs into whatever app you want to use on your phone, and it's going to tell you if there's a gap. It's going to tell you if there's a delta gap. But again, I want you to understand what's going on behind the scenes. So I want to go through a few different examples to make sure you understand what delta delta actually is referring to and why that's clinically relevant. Okay, so our first example, and again, this is not, I'm not going over our approach to an acid-based problem. I just strictly want to illustrate delta delta. All right, so say we start out with a sodium of 135, a chloride of 100, and a bicarb of 15. Okay, so what's your gap? It's basic math. 135 minus 100 is 20. Okay, so 20 is greater than 12. So we have a positive anion gap acidosis just by looking at these 3 numbers. So if we have a gap of 20, assuming that all was normal before the onset of this disorder, what should the patient's gap have been? Don't overthink it, it's 12. So before all this started, patient likely had a normal gap of 12. Now we have a gap of 20. So the first part of delta and delta delta is the difference between a normal gap and your actual gap. So what is the difference of our actual anion gap compared to a normal anion gap? It's 20 minus 12. Okay, so this is the actual anion gap that we calculated to be 20. Normal is 12. So that means the first delta in our delta delta is 8. All right. So we've already said that if we have a gap, that means there's an addition of an acid, which means there's a buffering of bicarb. So if there is a difference of 8, then you can infer that that means we've recently lost 8 bicarbs, because 8 bicarbs had to be used to buffer the extra acid. Okay, so if our bicarb is currently 15, and that's what I gave you to start with, and we know that we must have recently lost 8 based off the delta anion gap, what was the patient's bicarb before this process started? Again, it's simple algebra, it's 23. So X, which is what we're looking for, minus 8, because we know that we've lost 8, is equal to our end result, which you're given, 15. So X is 23. So in this case, delta delta is 23, which is a normal bicarb. So since we have a normal bicarb, you can assume there's no other accompanying metabolic disorder. That makes sense? Let's do a couple of other examples because I think some people kind of struggle with the concept of delta delta. So here we go. Sodium 135, chloride's 110, bicarb is 5. Okay. What's your gap? It's 20. So your total gap is still 20, which tells us you've got a gap acidosis. Again, assuming all was normal before all of this started, what should it have been? 12. So again, our delta anion gap is the difference between those two. Again, it's 8, just like our first problem. So again, if we've lost 8 and our current bicarb is 5 this time, what was it before this process started? 13, okay? Using your algebra. So 13 is a low bicarb. If you just look at that in a vacuum, 13 is a low bicarb. So what that tells you is calculating this delta delta, if your bicarb is low, then you have an additional acidosis, but it can't be a gap acidosis. It's got to be a non-gap acidosis. So if you were given these numbers after running it through, the delta delta equations, you know that you not only have a gap acidosis, but given this bicarb is lower than what it should be, there must be another non-gap acidosis. Okay, let's do one more problem. Again, our numbers are just a little bit different, but we have the same gap of 20. We know that before all this started, the gap should have been 12. So our initial delta gap is 8. So if our current bicarb is 22 and we recently lost 8, that means we should have started with a gap, with a bicarb of 30. Okay, so you can, and which is a little on the high side, so you must also have an accompanying metabolic alkalosis. Okay, so the whole point of figuring out what your delta delta is to see, is your bicarb what it should be based off the numbers that you have. If it's low, then you must have an accompanying additional non-gap acidosis. If it's high, you got to have a metabolic alkalosis as well. Okay, so that's why we check the delta delta. Now, again, you can plug all your numbers into a calculator and get these answers really quick, but I just wanted to show you through some examples why that implies whether or not you have another metabolic disorder. Okay. All right. So our next question is there an accompanying respiratory disorder? I'm sure you guys remember how we figured that out. It's using Winner's formula. Okay, which is what Winner's formula does is gives you an expected CO2 level based off your bicarb. Okay, so you just plug your numbers in to this equation and you get an expected CO2. And if your expected CO2 is higher than your actual CO2, that tells you you've also got to have a respiratory acidosis. If your expected CO2 is lower than what you actually have, then there must be a respiratory alkalosis. That makes sense? I'm not going to go into Winners as much as I did delta delta because I think it's a little bit more intuitive. And I think we're a little bit more comfortable with respiratory disturbances. Okay, any questions about metabolic acidosis, about gap versus non-gap, about delta delta, about Winners? Okay. All right, let's move on to a metabolic alkalosis. Now, I previously said that a metabolic alkalosis is the result of too much bicarb, right? And we'll get into that. Clinically, the majority of the time, a metabolic alkalosis is going to be due to loss of gastric fluid, usually vomiting, or diuretic use. Okay, but let's kind of dig a little bit deeper so you can understand what's going on. Now, these I've looked at these slides a bunch. The next few feel kind of clunky to me, but when I get to the end of this section, I think I'll bring it all together. So stop me if you have questions, okay? As I mentioned, for metabolic alkalosis, the main question you have to ask, is it chloride responsive or chloride resistant? So the first mechanism that can produce too much bicarb, forming a metabolic alkalosis, is through the activation of the RAS system. So like we talked about in our heart failure lecture, and like we talked about in our hyponatremia lecture, and like we'll talk about in our cirrhosis lecture next month, the RAS system gets activated when it senses reduced circulating volume, okay? So that's one way that you can get a metabolic alkalosis, and we'll go into it a little bit deeper. The other mechanism is through a chloride resistant metabolic alkalosis. And here there are kind of two different etiologies. You have settings that lead to inappropriate renal excretion of sodium chloride, and that ultimately results in serum bicarb being formed. Or is there exogenous bicarb being administered through some way? Okay, so let's start with the chloride responsive, and we'll break it down a little bit more. So these are the most common causes of a chloride responsive metabolic alkalosis. Again, if there is a chloride responsive metabolic alkalosis, it's due to activation of the RAS system. Generally, it's going to be due to vomiting or NG tube suction, fluid volume loss or contraction, or overdiuresis. And there's a lot of physiology and a lot of chemistry going on behind the scenes here, which I'm not going to get into because it's not really high yield. But in short, in these situations, when the RAS system is activated, you're going to get bicarb reabsorption in the proximal tubule, which ultimately will increase your serum bicarb level. Okay. So in short, for chloride responsive metabolic alkaloses, there's going to be loss of acid in the urine. Okay, so you're going to be peeing out carbon dioxide and hydrogen in the urine and holding on to serum bicarb. And there's and formation of bicarb in the serum. Those two things will lead you to an alkalosis. Okay, too much bicarb, not enough acid. Okay, so our second category, which is chloride resistant, is made up of two different buckets. So the first is situations in which there is inappropriate excretion of sodium chloride in the kidneys. Most commonly, this is going to be caused by some adrenal issue or corticoid issue. Sometimes you can see it in severe hypokalemia. You'll see it in these really rare renal disorders like Barter's and Gittleman's. But like with our other example, the chemistry here really is kind of complicated, but there's going to be activation of multiple different pumps that ultimately is going to lead to loss of hydrogen in the urine, loss of chloride in the urine, and a gain of bicarb in the serum, which again leads us to our metabolic alkalosis. And then our last bucket, which is much smaller than the others, is what I call exogenous bicarb, which isn't a perfect description, but usually this is from people eating too many Tums, and Tums are alkaline, and that's why they're really effective in neutralizing acid reflux. We also see this in packed red blood cell transfusions. The preservative in the packed cells contains citrate, which through some complex chemistry results in the formation of bicarb. Okay, so again, leaving us with a metabolic alkalosis. Okay, so all that stuff, like I said, is a little confusing to me, so I wanted to show it to you this way, which I think makes it a little bit easier. If you diagnosed a metabolic alkalosis, knowing whether or not it's chloride responsive will help you both diagnostically and therapeutically. Okay, so let me show you what I mean. If it's chloride responsive, you know that only happens in situations in which the RAS system has been activated. Your urine chloride is going to be low. The patient's often hypotensive, which again makes sense. You're not going to activate this RAS system unless you're hypotensive or unless there's reduced circulating volume. And often the patient needs more fluids, or you need to stop diuresis. On the other hand, fluids aren't going to help you in chloride resistant metabolic alkalosis. Okay, so there's nothing that's activating the RAS system. These patients are often hypertensive. As I mentioned, they're peeing out urine chloride. So the urine chloride will be high. Fluids won't fix the problem, and you really need to start considering other more rare things. Okay, so if you look at some of the common causes here for chloride responsive metabolic alkalosis, this is most commonly what we see in the hospital. So that kind of makes sense. If you've overdiuresed somebody, you've got to stop, or if they're vomiting, they need fluids. if it's a chloride resistant metabolic alkalosis, there may be some other more rare things going on. So the take home point here is if you have an unexplained metabolic alkalosis, check a urine chloride. Okay, so if your urine chloride is low, then it pretty much tells you this patient probably needs fluids or stop diuresis. If you have an unexplained metabolic alkalosis and your urine chloride is high, you need to be considering these other rare things or call renal, basically. Okay, any questions about that? Okay. All right, let's move on to our next disorder. Okay, respiratory acidosis. As I mentioned, the two questions you have to ask here: is it acute or chronic, and is there an accompanying metabolic disorder? So let's start out here. So how do you determine if a respiratory acidosis is acute or chronic? So history is really important. Oftentimes it's pretty obvious from history if there's an acute issue or not. And a very rough determination is if the pH is normal and your bicarb is elevated, then it's probably chronic. So that's a rough estimate, but that's going to get you in trouble in the setting of mixed disorders. Okay, so we need a more precise method of determining if it's acute or chronic. So acuity of a respiratory disorder is determined by comparing your measured pH with an expected change in pH. So this is like our Winner's formula, where you're getting an estimated value and comparing it to your actual value. You're doing the same thing for your respiratory disorders in terms of pH, and that'll tell you if it's acute or not. So for every 10 points of change in your CO2, your pH should change by 0.08 if it's acute, or 0.04 if it's chronic. Okay, so let me show you what I mean here. These numbers are intentionally a little whacked. They don't quite make sense. I'm just trying to illustrate a point here. If you were to just look at the numbers and I saw a pH of 7.2, I'm going to presume it's probably acute because you're not going to live very long if it's chronic. Again, if I saw a bicarb of 70, I'm going to assume that's chronic because you can't get your bicarb up that high quickly or acutely. But let's look at these ratios to determine acuity of the respiratory disorder. So let's assume that this is acute. Okay, so like I said, for every 10 change in PCO2, the pH should change by 0.08. So how many tens of PCO2 is our value, which is 70, above normal, which is 40. So 70 minus 40 is 30. So that's 3 tens, or 3 dimes worth. So this part says 3, and if we're assuming it's acute, we know that the pH has to change by 0.08. So 3 times 0.08 is 0.24. If we subtract this value from a normal pH, it gives us 7.16. That's not equal to our pH of 7.28, so it's not acute. Okay, so let's assume that it's chronic. And we'll do the same math. For every 10 change in PCO2, the pH should change by 0.04. Again, we have 3 dimes worth of change in our CO2. So 3 times 0.04 is 0.12. And therefore, if we take a normal pH minus 0.12, we get 7.28, which is exactly what we started with. So based off of these ratios and given these numbers, you can determine that this respiratory acidosis is chronic. Now, again, these numbers don't really make sense, aren't really intuitive. I'm just showing you this is the math that you would use to figure out if this is an acute respiratory acidosis or a chronic respiratory acidosis. Okay, so the next question that we have to ask for any respiratory disturbance is there an accompanying metabolic disorder? Okay, so you got some more ratios you got to memorize. For an acute respiratory acidosis, well, let me back up a little bit. Just like we did with our pH and just like we did with the Winner's formula, you're going to try to determine what your bicarb should be based off the values that you start with. And if that end result is different than what you would expect, then it tells you there must be another disorder present. So we know that our bicarb, so if you have a respiratory acidosis and your kidneys are trying to compensate by raising your bicarb level, if it's done acutely, it's going to happen slowly. And so for every 10 millimoles increase of PCO2, your bicarb will go up by 1 milliequivalent. If it's chronic, you've got a little bit more time for your kidneys to adjust, and it'll go up by 4 for every 10 change in PCO2. Okay, so that verbiage is a little bit awkward. So let's use pennies and dimes as an example. So if it's an acute respiratory acidosis, for every dime change in PCO2, there's going to be a rise of 1 penny of bicarb. And then for your chronic issues, for every dime change, there will be a rise of 4. And this should make sense when we look at these graphs. So, respiratory acidosis is essentially just hypoventilation. And as the lungs fail over time, your PCO2 levels will rise, right? So as this is happening, our kidneys are doing their best to compensate, and they're trying to excrete more hydrogen and hold on to more bicarb. But this takes time. This doesn't happen quickly. It can take days for this compensation to occur. So our bicarb will rise, but it's going to take some time for us to notice a significant change in our bicarb. So if you were to happen to see the patient in the acute setting and you check a bicarb, it may be normal or just starting to compensate. Whereas if it's chronic, the kidneys have had more time to adapt and the bicarb is going to be higher. Okay, so let's bring these graphs together. For, again, your blue line represents the rise of CO2, orange line represents the rise of bicarb over time. If it's acute and you catch the patient right here, as the CO2 rises, you're only going to get a minimal rise in bicarb because it's happened relatively recently. As time goes by and you see this patient chronically, the kidneys have had more time to adapt, and so your bicarb will be higher. Does that make sense? Okay, so to actually answer our question, like I said, if it's acute, for every dime change in your PCO2, there should be a rise of 1 penny of bicarb. So if your bicarb, based off that ratio, if your bicarb is higher than expected, okay, so again, you got too much bicarb that you can't explain from a respiratory compensation, that means you also have a metabolic alkalosis. At the same time, if your bicarb is lower than what you would expect, then that tells you there has to be an additional acidosis that isn't explained through a respiratory mechanism. So it must be a metabolic acidosis. That makes sense? Okay, so as I alluded to earlier, the primary issue in respiratory acidosis is hypoventilation. So really, no matter what's going on, it all begins and ends with hypoventilation. So anything that causes hypoventilation can cause a respiratory acidosis. And if you're looking at your most common causes of respiratory acidosis, through different mechanisms, all of these things lead to reduced ventilation, which leads to a rise in CO2. Okay. All right, so let's finally talk about respiratory alkalosis. Now, just like with our acidosis, there are just 2 questions we have to ask ourselves. Is it acute or chronic? And is there an accompanying metabolic disorder? Okay, so you work through them the same way. Really, the difference is the directions in which individual values change and the total amount of change. So in terms of expected change in pH, it's the same for a respiratory alkalosis. For every dime change in PCO2, if it's acute, your pH will increase by 0.08. If it's chronic, your pH will increase by 0.04. So nothing's different there. In terms of figuring out if there's an accompanying metabolic disorder, again, it's the same thing, but here our ratios are a little bit different. Instead of using 1 and 4, we're using 2 and 5. Okay, so if there's an acute respiratory alkalosis, for every dime change in PCO2, there's a decrease of 2 pennies worth of bicarb. Okay, and it's just slightly more for a chronic respiratory alkalosis. So if you plug your numbers in to those ratios, again, if your actual bicarb is higher than what you would expect, then there must be another metabolic alkalosis. Whereas if your bicarb is lower than what you should expect, if this were just an acute respiratory alkalosis, there must be an additional disorder. Is it metabolic acidosis in that sense? Just counter to our respiratory acidosis, there's one main driving force here for the alkalosis, and it's hyperventilation. So anything that leads to hyperventilation can cause a respiratory alkalosis as you blow off too much CO2. So these are some of the most common causes of a respiratory alkalosis, and all of them lead to hyperventilation in some way. Now, for a few of these, they're pretty intuitive. You know, if you're anxious and you're breathing too much, there's psychogenic hyperventilation. And that's why you see in movies or on a plane or whatever, you'll see people breathing into a brown paper bag when they're anxious. The reason for that is they're rebreathing some of that CO2 back in. So that the paper bag traps the CO2, they breathe it back in to try to get their CO2 levels down, or sorry, back up. If you're hypoxic, the hypoxia is going to stimulate an increased respiratory rate, which leads to increased ventilation. Of course, we have iatrogenic hyperventilation for our intubated patients as well. Now, some of these other conditions like fever and sepsis, pregnancy, cirrhosis, these all can cause respiratory alkaloses too, though the complex or the mechanisms are either really complex or kind of poorly understood. I'm not going to get into that, but essentially, if you have a respiratory alkalosis, you're blowing off too much CO2 through hyperventilation. Okay. So, the way we think about primary respiratory disorders is a little bit more intuitive because they basically lie along the same spectrum of disease. This is in contrast to our metabolic issues, which seem to be a little bit more confusing, even though they all deal with bicarb. So, on the far left end of the spectrum, you have an acidic situation resulting in a low pH that came from hypoventilation, and you've got just the opposite on the other end. Okay. So since our respiratory disorders are on the same spectrum, but just in opposite directions, I like using this little reference guide to remind you of the things that we just talked about. So for either one, your change in PCO2 will affect the pH in this manner. And when you're trying to determine if there's other metabolic disorders present, using this 2x2 table, you can see what ratio you should use for a respiratory acidosis, what ratio you should use for a respiratory alkalosis, and whether or not it's acute or chronic. Okay. And in the next session, when we actually go through problems, I think this will make a little bit more sense if there's anybody that's confused. Okay, so we got just a few more minutes. I want to at least mention the approach to solving an acid-base problem, and then at 2 o'clock we'll actually go through several examples. Okay. So step 1, pretty straightforward. You've got to determine if the patient is acidemic or alkalemic. Okay. If you've got a low pH, it's acidemia. If you've got a high pH, it's alkalemia. All right. Step 2 is determining whether or not determining if the primary disturbance is respiratory or metabolic. So you've looked at your pH, you've determined if it's an acidic situation or alkalotic situation, which will give you your first branch off. So say the pH is low, say that there's acidemia. If the bicarb's low, it's a metabolic acidosis. If your CO2 is high, it's a respiratory acidosis. Same thing for alkalemia. If your pH is high, look at your bicarb. If it's high, it's a metabolic issue. If your PCO2 is low, it's a respiratory issue. Okay, once you've done that, the next step, if it's respiratory, is to determine if it's acute or chronic. All right. If it's metabolic, your next step is to determine if there's an anion gap. And then your last step is to determine the presence of other disorders. So if it's metabolic, you're going to use delta-delta. to see if there's another non-gap acidosis. You're going to use Winner's formula to see if there's a respiratory disorder. If it's a primary respiratory issue, you're going to use those ratios that I showed you that will give you an expected change in bicarb. And if it's not exactly what you expect, you know there's got to be a metabolic issue as well. So this is the basic way that I approach each problem. Okay, so we can stop there. Like I said, if you can make the 2 o'clock workshop, I think it'll be really helpful and kind of tie all this together in a practical way. But we're going to work through several problems. You can see the different things that we'll work through, and I'll show you how to go through it step by step, and work through a gap acidosis, work through a respiratory alkalosis, work through toxic alcohol ingestions, work through mixed disorders. Okay. Any questions? Again, I can't hear you guys if you joined late, so please put them in the chat if you've got any questions. Okay. All right. If y'all think of some questions afterwards, just let me know. And if you can make it at 2 o'clock, great. If not, it'll be recorded. And I really encourage you guys attending or watching the workshop. I think really that's what I wanted to hit on. This was all just laying the groundwork, just so I don't have to take time to go over all the different terminology and all that stuff. But I think the workshop is really going to be helpful. So we'll get this uploaded to our YouTube channel. I'll record the workshop, and then we'll have it all together. Okay. All right, guys. Thanks for attending, and hopefully I'll see you at 2 o'clock. All right. Bye.